All right, today we're going to talk about the lungs. The first thing we're going to talk about is the negative pressure ventilation. So ventilation or breathing involves the movement of air into and out of the lungs driven by differences in air pressure. Air always flows from a region of high pressure to a region of low pressure. The body achieves these pressure differences by changing the volume of the thoracic cavity based on Boyle's law, which states that pressure and volume are inversely related. If gas volume decreases, pressure increases, and vice versa. The mechanisms and the pressures for inspiration. So there's muscular action. The two main muscles for quiet inspiration are the diaphragm and the external intercostal muscles. Volume and pressure changes. These muscle contractions increase lung volume by approximately 500 milliliters during quiet breathing. As lung volume increases, according to Boyle's law, the pressure inside the lungs, known as alveolar pressure, becomes negative relative to the atmospheric pressure, which is considered to be zero. This pressure gradient causes air to rush into the lungs until alveolar pressure equals atmospheric pressure, stopping inspiration. Then we have pleural pressure, and so the pleural pressure is in the pleural cavity, the space between the lungs and the visceral pleura, and the thoracic cavity's parietal pleura, maintains a negative pressure. This negative pressure is created because lymphatic vessels continuously pump fluid out of the pleural cavity, forming a partial vacuum. Additionally, the lungs' inward elastic recoil and the surface tension of water molecules in the alveoli also contribute to pulling the lungs away from the thoracic wall, increasing the pleural cavity volume and further lowering the pressure. Transpulmonary pressure. The difference between pleural pressure and alveolar pressure is called transpulmonary pressure. A larger transpulmonary pressure means greater inflation of the alveoli and lungs. So in quiet inspiration, this is a passive process that's resulting from the relaxation of the inspiration muscles. The diaphragm relaxes and returns to its dome shape. The external intercostals relax, allowing the rib cage to descend. The natural elasticity of the lungs tissue causes it to recoil into a smaller resting position. This decrease in thoracic cavity volume increases alveolar pressure to slightly positive relative to atmospheric pressure, causing air to flow out of the lungs. A pneumothorax is a clinical emergency where air is introduced into the pleural cavity, causing the lungs to collapse. It occurs when an external source air enters from an external source or from an internal source where it's not supposed to come from. A particularly dangerous type of pneumothorax is a tension pneumothorax. It's when a one-way valve forms from a damaged tissue, allowing air to enter the pleural cavity during inspiration but trapping it during expiration. This leads to a dangerous buildup of pressure in the thoracic cavity, which can compress veins, returning blood to the heart, leading to decreased venous return and life-threateningly low cardiac output. Emergency treatment involves inserting a large needle between the ribs into the pleural cavity to relieve the pressure. Pleuritis. An infection of the pleura can cause excessive fluid accumulation in the pleural cavity. If too much fluid builds up, the visceral and parietal pleural layers lose their adherence, which can lead to lung collapse. We talk about surfactant, surface tension, and Laplace's law. Surfactant defined, that's a detergent-like substance secreted by type 2 alveolar cells within the alveoli. It's essential for adequate ventilation. Surface tension is the interior surface of the alveoli is moist due to the high humidity of the inspired air. The molecules lining the alveoli strongly attract each other, creating surface tension that constantly pulls on the alveoli, making them resist this tension and tend to collapse. While this force aids in exhalation, it raises the pressure of the alveolar air and poses a risk to of alveolar collapse. When we talk about Laplace's law, this law describes the relationship between pressure, surface tension, and the radius of a sphere. And it can change with or without surfactant. When we talk about clinical relevance of these things, we talk about infant respiratory distress syndrome, which occurs in premature babies when their lungs haven't developed enough to produce adequate surfactant. Without surfactant, the alveoli are much more elastic, requiring significant energy expenditure for the infant to inflate their lungs. This manifests as rapid breathing, flaring nostrils, and intercostal reactions. Treatments include positive pressure ventilation and sufficient surfactant replacement therapy. And we talk about alveolar gas equation. So the alveolar gas equation is a crucial clinical tool used to calculate the expected partial pressure of oxygen in the alveolus. Since directly measuring is impractical, this equation allows clinicians to estimate it using readily available variables. The equation is The partial pressure of oxygen in the alveolus is equal to the fractional concentration of inspired oxygen times the atmospheric pressure minus the water vapor pressure minus the arterial partial pressure of carbon dioxide and the respiratory exchange ratio. By calculating the expected pressure of oxygen in the alveolus and then comparing the actual measured oxygen concentration in the arterial blood, clinically you can identify there's the pathology affecting gas exchange. If the values are significantly different, it indicates an issue in the lungs' ability to transfer oxygen, even if overall ventilation appears normal. When we talk about oxygen and carbon dioxide transport in the blood, gases move between the lungs, blood, and tissues, all according to partial pressure gradients, which is described in Dalton's law and Henry's law. When we talk about oxygen transport, oxygen is inhaled into the lungs where its partial pressure is high. It then diffuses down its pressure gradient into the pulmonary capillaries where the pressure is lower. Once in the blood, oxygen is transported in two main ways. One way is dissolved in the plasma, so a small portion of your oxygen is dissolved directly into the plasma. But it's a little amount because oxygen isn't very soluble in water. The other way is bound to hemoglobin. So most of your oxygen is going to be transported bound to hemoglobin because hemoglobin contains 4 iron-containing heme groups, each which are capable of binding a oxygen molecule. The oxygen hemoglobin dissociation curve. This curve illustrates the relationship between the partial pressure of oxygen and the percent oxygen saturation of hemoglobin. When we're talking about factors influencing hemoglobin's affinity for oxygen, the affinity of hemoglobin for oxygen can change, causing the dissociation curve to shift left or right. A rightward shift indicates decreased affinity, and a leftward shift indicates increased affinity. The things that can affect the hemoglobin's affinity for oxygen are carbon dioxide, acidity or pH, 2,3-diphosphoglycerate or BPG, exercise, and temperature. We're going to talk about fetal hemoglobin and carbon monoxide. Fetal hemoglobin has a greater affinity for oxygen than adult hemoglobin. This is partly because it lacks the ability to bind 2,3-BPG, allowing the efficiently grab oxygen from material in the blood and the placenta. Carbon monoxide. Carbon monoxide is extremely dangerous because carbon monoxide has an affinity for hemoglobin up to 300 times greater than oxygen. If it binds to the same site as oxygen, it can severely reduce the blood's oxygen carrying capacity. Treatment often involves 100% oxygen in hyperbaric chamber to increase the partial pressure of oxygen to compete with the carbon monoxide for the hemoglobin binding sites. When we talk about the carbon dioxide transport, it's the last thing we're going to talk about. Carbon dioxide is a byproduct of cellular respiration. It diffuses from tissues into the blood and is transported to the lungs in 3 main ways. The first way is when it's dissolved in the plasma. A small amount of carbon dioxide remains dissolved directly in the plasma. The second way is bound to hemoglobin. So carbon dioxide binds to the amino acids of the globin protein portion of the hemoglobin. And 3 is a bicarbonate ion. Most carbon dioxide is transported as bicarbonate. In the tissues, carbon dioxide enters red blood cells where the enzyme carbonic anhydrase rapidly catalyzes its reaction with water to form carbonic acid. Carbonic acid then dissociates into bicarbonate and hydrogen ions. The hydrogen ions released typically bind to hemoglobin, which helps buffer the blood pH changes and also triggers the Bohr effect. Bicarbonate ions leave the red blood cells in exchange for chloride ions, a process called the chloride shift, maintaining electrical neutrality. In the lungs, when alveolar pressure, carbon dioxide pressure, is low, carbon dioxide diffuses out of the blood into the alveoli. This reverses the carbonic anhydrase reaction within red blood cells, converting bicarb and hydrogen back into carbon dioxide and water, allowing carbon dioxide to be exhaled. The last one is the Haldane effect. This effect describes how oxygen binding to hemoglobin decreases hemoglobin's affinity for carbon dioxide, facilitating the release of carbon dioxide in the lungs. Conversely, when oxygen leaves the hemoglobin in the tissues, hemoglobin's affinity for carbon dioxide increases, promoting carbon dioxide uptake. This means that deoxygenated blood can carry more carbon dioxide than oxygenated blood.